Welcome to Sleep Review's webinar, comparing various forms of positive airway pressure therapies for sleep-disordered breathing and heart failure. Today's presenter is Dr. Salma Patel. Welcome, Dr. Patel. We're ready to hear your insights.
Thank you. So we're going to start by going through some background regarding heart failure. There are about 5.1 million people in the United States with heart failure, and this was back in 2006. And we know that the incidence is increasing, and so are the number of hospitalizations. About 40 to 60% of patients with heart failure have diastolic dysfunction or a normal left ventricular ejection fraction, which means that the other 50 or so percent have heart failure with reduced ejection fraction. And it's important to differentiate between the different types of heart failure because it affects the phenotype of the sleep disordered breathing. And you will see this here in just a little bit. So there were two large US studies done trying to describe the prevalence of sleep apnea in patients with reduced ejection fraction. And they found that for moderate to severe sleep apnea, described as an apnea-hypopnea index of over 15 per hour, the prevalence was about 49 to 61%. And a majority of them had central sleep apnea, 31 to 37%, and followed by obstructive sleep apnea, 12 to 30%. A similar study done in patients with preserved ejection fraction found that the prevalence of sleep apnea is about the same, 48%, and this is for moderate to severe sleep apnea. 23% of them had central sleep apnea, and 25% had obstructive sleep apnea. If you look at this pooled analysis of all of the studies done worldwide, and the bars in blue show patients with low ejection fraction, and red those with normal ejection fraction, you'll see that the prevalence of central sleep apnea tends to be a little bit higher in those with low ejection fraction compared to those with a normal ejection fraction. Now, why are we even concerned? We know that obstructive sleep apnea and central sleep apnea both have significant adverse effects, including hypoxemia, hypoxemia followed by reoxygenation, and we know the impact of reactive oxygen species. There is hypercapnia and hypocapnia, increased sympathetic activity followed by release of hormones, including cortisol, which have impact on all organs in our body, reduced left ventricular ejection fraction, unlikely to get into deep sleep, excess morbidity, hospital readmissions, and mortality. And so when we have put patients with heart failure and obstructive sleep apnea on CPAP, we have found that it improves left ventricular ejection fraction, blood pressure, and decreases hospitalizations and mortality. Here you'll see a figure that goes through Medicare files from 2003 to 2005 for patients with newly diagnosed heart failure. And you'll see in this Kaplan-Meier plot that those patients in red who were tested, diagnosed, and not treated had a significantly higher mortality rate compared to those in green who were diagnosed, tested, and treated. And a similar study, this was a prospective study, this was a famous PAP trial done in patients with central sleep apnea and heart failure with an ejection fraction less than 40%. And patients were randomized to either a control group or a CPAP. And you can see on these figures that definitely the apnea-hypopnea index was reduced and the oxygenation improved for patients on CPAP. And also their left ventricular ejection fraction was improved. Now, this study failed to show an improvement in transplantation-free survival, overall survival, and hospitalizations per patient, which left most of us people in sleep medicine scratching our heads. And then came the post-hoc analysis, which fixed the scratching problem because we ended up finding out that in the PAP trial, 47% of the patients who were analyzed had inadequately controlled central sleep apnea on CPAP. And when they looked at left ventricular ejection fraction based on whether the apnea-hypopnea index was controlled and the central sleep apnea was suppressed, you'll see on the graph on the left that their ejection fraction significantly improved, and the graph on the right shows that their heart transplant-free survival was actually significantly improved. And this study treated patients with obstructive sleep apnea and heart failure with reduced ejection fraction with CPAP. You can see their ejection fraction for both obstructive and central sleep apnea. They were in the low to mid-20s. The AHI was in the severe range for both obstructive and central sleep apnea. And the patients who had obstructive sleep apnea responded beautifully. Their AHI dropped, their oxygenation improved, as shown on the graph here. But the patients with central sleep apnea didn't do as well. This graph is a little deceiving because it goes over the responders to CPAP. 57% didn't respond to CPAP on this study. And so CPAP generally works to treat obstructive sleep apnea, but not central sleep apnea, and therefore other modalities are needed. And so we should go over some of those other modalities. There haven't been a ton of studies done using BiPAP-S, which is BiPAP in the spontaneous mode. There was this one small study done where they randomized 21 patients with idiopathic dilated cardiomyopathy for BiPAP to BiPAP-S or standard medical therapy. And they did find that there was a significant improvement with BiPAP-S compared to standard medical therapy. The AHI was significantly improved, and there was a tendency towards improvement in survival. Now, BiPAP in the spontaneous mode has the possibility of aggravating central sleep apnea because of hyperventilation. And so currently this isn't a general go-to mode of therapy until further studies are done. And how about BiPAP-ST? So this is BiPAP in the spontaneous time mode. And there have been several studies done that show significant improvement in left ventricular ejection fraction and the apnea-hypopnea index. And one of these studies was also done in patients with CPAP failure, and they responded very well in terms of their central sleep apnea. And then finally, adaptive servo-ventilation. So this provides a varying amount of anticyclic inspiratory pressure support during different phases of periodic breathing and augments ventilation if it's below target. The newer generations of ASV also provide varying EPAP or expiratory positive airway pressure support. There was a one-night study done in patients with heart failure with reduced ejection fraction and central sleep apnea and compared ASV to oxygen, CPAP, and the other bilevel devices, and it found that ASV was superior in decreasing the apnea-hypopnea index. There have been multiple studies done on ASV that show improvement in biomarkers of heart failure, so brain natriuretic peptide, left ventricular ejection fraction, mortality, and hospital readmissions. Now, ASV was standard of care until May of 2015 when the field safety notice came out after the Servo-VTF trial. And so we'll talk about this Servo-VTF trial. Servo-VTF randomized patients with an ejection fraction less than 45% and an apnea-hypopnea index over 15 with predominantly central events to either ASV or medical treatment alone. And the graphs here will show to you that the all-cause mortality and cardiovascular mortality was thought to be higher with ASV compared to the control group. And that's what resulted in that public safety announcement. So what was the issue with the Servo-VTF trial? There are still plenty of unanswered questions. So the table here shows that it's from the supplementary material published by this study. And you'll see that they had very varied apnea-hypopnea indices on treatment, as high as 72 at 3 months of treatment. They also used an old generation ASV device, which means that there was no adjustable expiratory positive airway pressure. And the ASV device was equipped with only increasing IPAP to address obstructive events, which will often end up with excessive ventilation, and that can cause arrhythmias and so on as a result of hypocapnia. And then there were adherence issues. So about 30% of, close to 30% of the subjects included in the analysis discontinued or never used the device. And currently, ASV devices are contraindicated for heart failure for patients with central sleep apnea when their ejection fraction is less or equal to 45%. Our site did a study to try and answer the question as to whether is the concern with adaptive servo-ventilation a mode effect of adaptive servo-ventilation, or is it a device effect? Was it a specific device perhaps used in the Servo-VTF trial? And so we randomized 14 patients with normal hearts and complex sleep apnea to 4 devices over 4 nights. So they got to try each one of these devices. And these included the ResMed S7, ResMed S9, Respironics System 1, and Respironics DreamStation. And we used the standard settings on all the devices and excluded those with untreated sleep disorders. And the most impressive finding was that the S7 device seemed to have a much higher minute ventilation during wake and for the entire night. About 14 to 40% greater with the S7 device. Now, if we overventilate the patient, we can induce hypocapnia, we can induce respiratory alkalosis, and that can result in hypokalemia. It is possible that this can prolong the QT interval, and we all know that QT interval changes can result in arrhythmias. Now, we did not notice in our study a change in QT based on device, but our study was not powered to answer this question. And then you wonder if this effect would be magnified in patients with heart failure. We did see a few more PVCs during some of the S7 nights. This wasn't statistically significant. And we did also see more non-sustained supraventricular tachycardia during the S7 nights, 2 of the S7 nights, and 1 during the System 1 night. And this just goes through what I went over in detail. Now, I'd like to share with you some unpublished data. This was presented this last weekend at the American Heart Association meeting. Claims data that we analyzed on over 1 million patients who were diagnosed with obstructive or with sleep apnea, either obstructive or central, and treated either with nothing, those are the control patients, or BiPAP S, BiPAP ST, or CPAP. And all patients of all ages were included over the age of 18. We had a good representation of males and females. And as would be expected, we had more patients in the BiPAP ST arm with cardiovascular morbidities, and there were more patients in the plain BiPAP S arm with pulmonary conditions or morbid obesity. And what you see here is that there is improvement in hospitalizations and heart failure-related hospitalizations. Regardless of what group they fell into, there was a tendency for much greater improvement with BiPAP S and BiPAP ST. And when we broke this down into obstructive and central sleep apnea or a combination, the same kind of findings were found in that BiPAP S and BiPAP ST seem to be a little superior to the control group. So there was improvement in heart failure-related hospitalizations. Oh, and this shows that there was improvement in overall hospitalizations. And so, to summarize, sleep apnea is very prevalent among heart failure patients, almost 50%. Central sleep apnea is more prevalent in patients with heart failure with reduced ejection fraction than in those with heart failure with preserved ejection fraction. CPAP therapy for obstructive and central sleep apnea generally results in positive outcomes. However, it's not always effective in patients with central sleep apnea, and we may have to go to either BiPAP S or BiPAP ST or ASC. Insurance claims data show improvement in number of hospitalizations for all patients on PAP therapy. And adaptive servo-ventilation is contraindicated in those with an ejection fraction less than 45%, less or equal to 45%. And more studies are needed evaluating the impact of adaptive servo-ventilation on sleep. I thank you for your time and interest, and we'll take questions.
Thank you for that insightful presentation, Dr. Patel. Sleep Review editors will now moderate the question and answer portion of this event. Audience, if you haven't already, use the Q&A box on the side of your screen to submit your questions related to sleep disordered breathing and heart failure. It should show up most likely on the right-hand side of your screen. It will say questions, and you can type in your questions there. Audience as well, if you want a PDF copy of the slide deck or a Word document of the references cited in today's presentation, you can download both of those files now in the handout section of your control panel. Dr. Patel, can you tell us how frequently do you need to monitor patients on ASV to ensure they don't fall into the contraindicated group?
That is an excellent question. So there aren't any specific guidelines as to how frequently to monitor echocardiograms on patients on adaptive servo-ventilation. There are hospitals and practices that will do it on an annual basis. My personal practice is to do a thorough physical exam every time the patient comes in, and you can often tell if there are symptoms of heart failure on exam. I always get a baseline echocardiogram, and then I do periodic clinical exams, and then I will do a repeat echocardiogram if indicated, or if the patient tells me something along the lines of, I had a heart attack a few months ago, or in the interim.
Excellent. Okay, next question. It seems like there are instances where patients would need to be on ASV. Do you have any problems convincing third-party payers to pay for ASV instead of, say, CPAP?
So for central sleep apnea, if on the sleep study you can show that the patient underwent CPAP titration, failed, the AHI was uncontrolled. They tried BiPAP-S, they failed, AHI was uncontrolled, BiPAP-ST was also attempted and failed, then almost all of them will let you get an adaptive servo-ventilator. But you'd have to qualify them by showing all the other modes failed during the titration study.
That makes sense. Can you tell us a little bit more about Servo-HF, and do you know anything about any new research that might be going on about ASV in heart failure?
Yeah, that's an excellent question. So Servo-HF was just completely unexpected for us sleep docs, and we weren't given all of the really strong evidence behind ASV, including improvement in ejection fraction and mortality and so on. We weren't expecting the findings in Servo-HF, and we went over the post-hoc analysis. There is the Advent-HF study that is trying to answer this question also prospectively. They had gone over some of the interim data during the last sleep meeting, and it sounds like ASV, there have been no safety concerns in the patients thus far randomized to ASV. However, until further research comes out and the information is actually published, the verdict is still out. But the current the recommendation is do not use ASV in patients with an ejection fraction less or equal to 45%. There's also a study that's coming out looking at oxygen use in patients with heart failure instead of PAP therapy. So LOFT-HF will be coming out soon, and those are the main ones.
Excellent. And audience, we do still have a few more moments for your questions. So if you have any questions related to anything that Dr. Patel went over today, please type those into your audience Q&A box now, and I will wait a moment for some additional questions. I guess, Dr. Patel, I have a question. How do you have the conversation with your patients who have heart failure about what type of device might be best for them, and particularly if they have to switch from one device to another?
That's a really good question. So, I share all of the research data with my patients, and I tell them about, so it depends, the conversation I have with them depends completely, depends on whether they have heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction. I often don't go into the details of like the Servo-HF trial with the patients with heart failure with preserved ejection fraction because we don't think that they have increased mortality with ASV, at least with the information we have thus far. In patients with heart failure with reduced ejection fraction, I will often tell them that adaptive servo-ventilation, so I'll go through all of the different modes, CPAP, BiPAP-S, BiPAP-ST, and then forms of BiPAP-ST, including ASV, with them. And I'll be very clear that we're going to try everything, and if they all fail, we won't try ASV in your case, even though that would be standard of care for other patients. And most patients are very understanding of that if you have that open conversation.
We have another question that came in. Would improving heart failure possibly change the mode of therapy used?
That is an excellent question. And I'm not sure anything has been published in that area. I know that they've done, so most of the studies I've quoted, the control groups are patients on optimal medical therapy, and the patients on the treatment groups are also on optimal medical therapy for heart failure. But as to whether they switch between groups, so does the central phenotype in someone with reduced ejection fraction change to obstructive, and you can downgrade from, let's say, a BiPAP ST to a CPAP, that research still has to be done.
Excellent. That sounds like a good idea for a future research project. Are there any other heart failure patients other than the ones with the specific reduced ejection fraction who should not be treated with ASV?
Yeah, at least not based on the information we have thus far.
Excellent. That makes sense. Okay, I'll give this another maybe 30 seconds if anybody else has any questions for Dr. Patel. And also just a reminder, if you would like to download the slides from today, you can do that on the right-hand side of your screen where it says handouts. There's also a list of references on the right-hand side of your screen. And on that references handout, there is also a link if you would like to download a free feature report. It's about 8 pages long about heart failure, treating heart failure patients who also have sleep disordered breathing. Excellent. Well, thank you so much. To finish on time today, I want to conclude by saying thank you to our presenter, our sponsor, and to our audience members. This webinar has been free for attendees, courtesy of sponsorship by Philips. Today's webinar was recorded, so you may rewatch it for free anytime. The link will be emailed out to all attendees after the event. Feel free to share the link with colleagues who may have missed today's live event. Email sroy@medcore.com with comments, questions, and future webinar suggestions, and visit us at www.sleepreviewmag.com. Thank you for participating in this Sleep Review webinar.